Welcome to The Code Trade, a podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine ICU pharmacist at the Mayo Clinic. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP EM PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
Hi, good afternoon, everybody. My name is Zack, Moreo, and I'm a current PGY2 emergency medicine pharmacy resident at Grady Health System in Atlanta, Georgia. Today, I'll be talking about hyperkalemic emergency department patients intubated with Rocuronium or Succinylcholine, retrospective study of clinical outcomes. Me nor my collaborators of this presentation have no disclosures. This trial was published early this year in the American Journal of Emergency Medicine by Simmer and colleagues. So currently, there's limited case reports to show the use of succinylcholine in hyperkalemic patients. If we focus our attention on the above study published in Anesthesia back in 2002, this is a review of patients who underwent intubation. 38 of these patients had a preoperative potassium of 5.6 or greater and received succinylcholine. Of the 38, 100% survived. There was no dysrhythmias or other major morbidities were documented. They concluded that succinylcholine may be appropriate and safe for use in certain patients with moderate hyperkalemia. We focus our attention to the bottom case report, published in Resuscitation in 1985. 9-year-old boy was scheduled for an adenoidectomy and bilateral tonsillectomies. He received nitric oxide and halothane and 20 milligrams of succinylcholine and had a short run of ventricular tachycardia. His ventricular tachycardia was abated with 1 milligram of propranolol and Influrane, and normal sinus rhythm returned. This was early evidence that succinylcholine may cause ventricular tachyarrhythmias. If we focus our attention on the bottom study published in 1997 in Chest, this was a case report, looked at 27-year-old female treated for acute respiratory distress syndrome. She developed hyperkalemia and cardiac arrest following administration of succinylcholine. There was no other risk factors, and throughout her hospitalization was treated with a non-depolarizing neuromuscular blocking agent, and they were able to fully resuscitate her, and she survived. As we all know, succinylcholine is a depolarizing agent, and this can cause transient increase in serum potassium. It's typically immediate right after administering the medication, and it lasts for about 5 minutes. The duration of succinylcholine is about 15 minutes. This study aimed to compare adverse clinical outcomes in patients with pre-existing hyperkalemia who received either succinylcholine or Rocuronium during RSI in the ED. This study was a retrospective cohort study of ED patients. This was conducted at a single health system, which was a level 1 trauma center and a tertiary care referral center. Patients included were adults who had initial serum potassium greater than 5.5 millimoles per liter and who required rapid sequence intubation with either Rocuronium or succinylcholine. Patients were excluded if they did not receive a paralytic during RSI. It was unclear what paralytic agent they received, or if they were intubated during cardiac arrest. The interventions in this study were Rocuronium and succinylcholine, and just want to highlight that there was no dosing strategies published for Rocuronium or succinylcholine in this study. The authors had a primary outcome of 24-hour mortality following paralytic administration, and a secondary outcome of cardiac arrest within 1 hour of paralytic administration. For statistical analysis, they used descriptive statistics and chi-squared tests. Non-dichotomous variables utilize chi-squared tests comparing largest groups to all others. Together, they conducted a multivariable logistic regression model trying to see if patient characteristics were associated with the primary outcome of death within 24 hours. There was 13,016 ED patients with hyperkalemia. Out of those, 447 underwent rapid sequence intubation, and 13 were excluded. There was 310 in the Rocuronium arm and 124 in the succinylcholine arm. The authors conducted further subgroup analyses. If we focus our attention on the gold box on the top, they excluded 50 patients with dialysis-dependent end-stage renal disease, and that had a new sample size of 260 patients in the Rocuronium group and 124 in the Succinylcholine group. So as you can see here, that all patients with end-stage renal disease on dialysis received Rocuronium in this study. If we focus our attention to the bottom gold box, 95 were excluded who received IV calcium prior to RSI. There was 220 in the Rocuronium group and 119 in the Succinylcholine group. And finally, if we look at the blue box on the far right-hand side, this excluded patients with dialysis-dependent end-stage renal disease and those who also received IV calcium prior to rapid sequence intubation. So there was 184 patients in the Rocuronium group and 110 patients in the Succinylcholine group. Groups overall were well balanced across the Rocuronium and Succinylcholine group. The average age was 62. Half of those patients were male, and their initial serum potassium were 6.4 in the Rocuronium group and 6.2 respectively. Also, as I previously mentioned, that patients with a history of ESRD, there was about 50 of them, were all in the Rocuronium group. And the majority of patients who received etomidate, majority of these patients received etomidate as their induction agent. And as you could see here, almost half of these patients did have a prior history of chronic kidney disease, with 49% in the Rocuronium group and 38.7% in the Succinylcholine group. The primary outcome of 24-hour mortality after paralytic administration found that there was no statistically significant difference between groups. 31 patients, or 10%, experienced death within 24 hours in the Rocuronium group, and 13 patients, or 10.5%, in the Succinylcholine group. And as we focus our attention on the second box, excluding all patients with dialysis-dependent end-stage renal disease, there was no difference in death among both groups. And then also, there was no difference observed in death in patients who were excluded, who received IV calcium prior to rapid sequence intubation. And when the patients on hemodialysis and received IV calcium were excluded, there was still no difference in death within those 24 hours in both groups. Looking at this forest plot for regression odds ratio for all encounters, a multivariable logistics regression model was ran assessing predictors of 24-hour mortality following RSI. Paralytic agent, Rocuronium versus Succinylcholine, was not significantly associated with 24-hour mortality. They did find that sepsis for the encounter or trauma activations were associated with higher odds of 24-hour mortality. And just want to highlight that these patients who present with trauma or sepsis may just be disproportionately at a higher risk of morbidity and mortality in general due to the disease state. Also, increasing age per year was associated with higher odds of 24-hour mortality. And this is in line in general with the increasing aging population. Patients have more comorbidities, and it just increases overall risk of a bad outcome in these patient populations. When looking at the forest plot regression odds ratio for Succinylcholine encounters only, they found that only increasing age per year was associated with higher odds of 24-hour mortality, and that serum potassium level, calcium administration prior to intubation, diagnosis of sepsis, or presented as a trauma activation, and other comorbidities such as CKD, congestive heart failure, type 2 diabetes, were not associated with an increased or decrease in 24-hour mortality. For the secondary outcome of cardiac arrest within 1 hour of RSI, 6 patients in the Rocuronium arm, or 1.9% of patients, had an arrest within 1 hour, and 1 patient in the Succinylcholine arm, or 0.8%. And when excluding patients on hemodialysis, excluding patients on IV calcium prior to RSI, and excluding patients who are on dialysis and who received IV calcium, there was still no significant difference in arrests within 1 hour of RSI between each group. So overall, the evaluation of the study, this is the largest study to date investigating hyperkalemic patients receiving succinylcholine for RSI. Patients included had an average potassium of greater than 5.5, as most RSI trials do exclude this patient population. The outcomes were adequate since this is an immediate risk period when succinylcholine-induced hyperkalemia should present. However, the weaknesses of the study were that it was a retrospective trial, so it decreases our overall external validity to apply it to practice. It wasn't adequately powered. There were no doses of paralytic agents listed. There may have been selection bias of patients with ESRD that received Rocuronium. And also, it may be underpowered to detect differences in patients with severe hyperkalemia greater than 6.5 to 7 millimoles per liter. Also, a weakness of this study was there was no mention of treating hyperkalemia prior to RSI in addition to IV calcium. Also, in the immediate period after succinylcholine administration, there was no mention of any EKG changes or if patients went into these ventricular tachyarrhythmias. In summary, the authors concluded that succinylcholine administration in patients with hyperkalemia did not result in increased 24-hour mortality compared with patients who received Rocuronium. Application to clinical practice. So what we can take away from this study are patients presenting with moderate hyperkalemia, K of greater than 5.5 millimoles per liter, may receive succinylcholine with limited adverse effects. In patients who have hyperkalemia where their K is greater than 6, 6.2, 6.5, I become more concerned and in that case would opt more for Rocuronium in that setting. Also, if there's comorbidities that also increase the patient's risk of hyperkalemia, such as if it's a burn injury or a crush injury, or if they have neuromuscular disease, in addition to high potassium of greater than 5.5, then may in this case would go to Rocuronium. And really at the end of the day, the choice of paralytic agent may be guided by clinical scenario more than by potassium levels themselves. So the key takeaway from this study was that the authors were unable to show any adverse events associated with succinylcholine hyperkalemic patients receiving rapid sequence intubation versus Rocuronium, and overall that these patients really are evaluated on a patient-by-patient basis and really understanding all their comorbidities or with whatever limited information that you have and making a clinical, utilizing your best clinical judgment in order to give the most effective medication. Thank you so much for your guys' time, and I'll take any questions.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.